Hey, Dr. Lofton, it's Jean-Luc. I hope your daughter's feeling okay. I didn't get the chance to present in rounds, so I wanted to take the chance and present to you via video. So hopefully this works. But I'm going to be presenting on the diagnosis and management of asymptomatic bacteria versus urinary tract infection in patients with spinal cord injury. And fun fact, one of my undergraduate majors was in microbiology, so I really love any kind of integration of this into physiatry as well. So first things first, we need to get specific with our definitions. Asymptomatic bacteria is the isolation of bacteria in an appropriately collected urine specimen from an individual who does not have symptoms of a urinary tract infection. And this definition comes from UpToDate, whereas a urinary tract infection, as defined by really any website, is an infection in any part of your urinary system, your kidneys, your ureter, your bladder, your urethra, and it generally presents with symptoms. The symptoms can be localizing, very specific to the urinary tract, or non-localizing. I think we see a combination of both depending on the level of the spinal cord injury. Our localizing symptoms are going to include our very classic dysuria, urinary urgency, frequency, incontinence, suprapubic pain, gross hematuria, CVA tenderness, whereas our non-localizing symptoms are going to be more of our fevers, our rigors, and our just clear-cut delirium that we often see in our elderly patients. So when I first started my research on this, I found that a lot of websites and algorithms were using pyuria as a distinguishing feature in determining between asymptomatic bacteria versus a urinary tract infection. Some also considered very much the classic leukocyte esterase, nitrites, as well as urine cultures. But the IDSA has very specific guidelines that a urinalysis does not distinguish between a urinary tract infection and asymptomatic bacteria. So I really wanted to investigate this pyuria a little bit further to see why people were recommending it and why the IDSA will recommend against it. And I found that the presence of pyuria has a pretty low sensitivity but a very high specificity. But what's really important is that it has a strong negative predictive value, and that the absence of pyuria is pretty strong in recommending against those with a urinary tract infection. Its positive predictive value is not great. It's about 70%, and specifying pyuria as 10 white blood cells per high power field. And so when we consider asymptomatic bacteria versus urinary tract infections in the spinal cord injury population, we see a high prevalence of bacteria as well as a high incidence of urinary tract infection in patients with spinal cord injury. I think a lot of times due to the neurogenic bladder as well as the introduction of catheters. It's important, and we're studying it very closely because patients with spinal cord injury and those who have a symptomatic urinary tract infection actually don't present with classic symptoms and may have symptoms that are not considered consistent with a presentation for UTI among other populations that we may see in the hospital. And I think this is likely the reason for the antibiotic treatment of many patients who have asymptomatic bacteria. What's interesting is that asymptomatic bacteria treatment with antibiotics is traditionally will be followed by an early recurrence of that same bacteria after antimicrobial therapy, as well as it could grow reinfecting strains that are more likely to be resistant to antimicrobials and can become multi-drug resistant. This acts very similar to C. diff when giving antibiotics in the gut. And also very similar to gut microflora is that preliminary evidence suggests that asymptomatic bacteria is actually protective in preventing urinary tract infections in patients with spinal cord injury and those who have impaired voiding. And so I mentioned the IDSA guidelines a little bit, and I just kind of wanted to refer to them. And they actually have very specific guidelines for the treatment of and testing of those with spinal cord injury for asymptomatic bacteria. They actually recommend against screening for or treating asymptomatic bacteria. As you can see, they have a strong recommendation, but the evidence is pretty low quality here, strictly due to the fact that the clinical signs and symptoms of a urinary tract infection experienced by patients with spinal cord injury will actually differ from and may differ from the classic GU symptoms experienced by patients who have a normal sensation. This atypical presentation of a urinary tract infection should be considered in making decisions with respect to treating or not treating those who have bacteriuria. But what this really led me to consider is, how do we even know when to treat these patients? And I looked further into the IDSA guidelines, and they have very specific signs and symptoms that they define as possibly indicative of a urinary tract infection in patients with a spinal cord injury. And so some of those symptoms include a fever, incontinence, or the onset or increase in incontinental episodes, including leaking around the catheter, as well as increased spasticity, malaise, lethargy or sense of unease, cloudy urine, or increased odor of the urine. That urine may have mucus or sediment, or it may not. They actually look at pyuria, as we talked about in the definitions before. It does have a strong negative predictive value, but its positive predictive value isn't as great. They also have, they specify about discomfort or pain over the kidney or bladder during micturition, as well as mention autonomic dysreflexia, which we see as more common in the spinal cord injury population. And so what the IDSA guidelines actually recommend is that if we look at the basic data set, a spinal cord injury patient who presents with a recent onset or change in the signs or symptoms described in that basic data set, who have bacteriuria and pyuria with no other obvious cause for the signs and symptoms, they may have a symptomatic UTI and they should be offered treatment. And just for fun, I emailed one of my mentors from Wilmington, who is an infectious disease and internal medicine physician. His name is Dr. Pan, and he did his fellowship at VCU and actually got to work in the rehab hospital about this topic. And he gave me some advice to research a little bit more of the IDSA guidelines. However, he said there's really no good data to guide management, and it's simply based on expert opinion. And so to answer Dr. P's question, I think we can use this international basic data set in order to help define whether this is bacteriuria versus a urinary tract infection in patients with a spinal cord injury. But if we're not really sure, I think consulting infectious disease is probably the next step. And I'd be very curious as to see what they say and what their justification for treatment versus not treatment is. What Dr. Pan mentions is that some patients have a unique tell or unique symptom that's associated with them developing a urinary tract infection. And so, Dr. Lofton, I'd be very curious as to what experiences you've had in patients who have this unique tell or symptom. And Dr. Pan also mentions that they've actually looked at different markers to help diagnose a urinary tract infection and haven't had any significant results. And I was curious, but I didn't include it in my presentation. They've looked at IL-6, so a pro-inflammatory marker in the urine, to see if it is associated with an increased tell for urinary tract infections. And it's kind of an expensive test right now, and it looks like the reproducible data is not so great. So I'd be curious to see where this comes in the future, because currently we don't have a great way to tell about bacteriuria versus a urinary tract infection. And these are my references so far. And so just thank you for the opportunity to present this. This was a very interesting topic and something I'm going to encounter in the future. Please feel free to email me with any questions that you have, and I hope you have a good evening.